I get asked many times from general dentists, what cases should I treat and what cases should I avoid? And the answer really comes down to APRA, the scope of practice. So every dentist must practice within their scope of practice, and hence the more knowledge they have, the more they can practice, whether it be in endodontics or periodontics, and obviously the same applies in orthodontics. As a general rule, I believe that you need to pick the low-lying fruit. And in orthodontics, I would imagine the low-lying fruit are those cases that you can treat comfortably within 18 months. Because they're the patients that you're going to get the best results with, the quickest results with, and you're going to have raving fans. Anything that goes after 18 months, the patients are just asking, when am I going to get my braces off? When am I going to finish my orthodontic treatment? And you have to say to them, it'll be soon, it'll be soon. But what you want is to promise less and deliver more. So if you tell them it's going to be 24 months and you can get the braces off at 18 months or the aligner therapy completed in 15 months, you look like a genius. You have the raving fans, you have the positive Google reviews. So from a high level point of view, I would say to you, only treat patients that you can comfortably complete with high quality outcomes in that 18-month period. So there are three types of patients that I would definitely avoid. The first type are those patients who've got very high or impacted canine teeth, a very common occurrence, especially in the adolescent group. Because for us to pull down those canine teeth could take at least 3 years of treatment, and the possibility of damaging other teeth as we bring down those canine teeth. So they're one group that I would not touch at all. That's not low-lying fruit. The second group are the patients who have an open bite, or patients that you may be scared that will develop an open bite. Most patients can live even with deep bites, with a deeper overlap, but they cannot live with an open bite where there's no overlap and they can't chew properly. So the worst thing we can do in dentistry or in orthodontics is end up with an anterior open bite. So I wouldn't be starting any patient who has an open bite in the first place, but I wouldn't even be starting a patient who might only have a minimal overbite, because the overbite will tend to open even further. So avoid patients with anterior open bites and avoid patients who've got minimal overbites, because they can develop into an anterior open bite. And the third group that I would definitely avoid is the class 3 skeletal, where the mandible is ahead of the maxilla, because what happens with normal growth, the mandible actually grows longer and further than the maxilla. And the last thing you want to be doing is doing orthodontic treatment for 18 months or 2 years or whatever it be. The mandible grows out of control, you end up with a reverse overjet, and now the patient has to undergo a further 2 years of treatment, but now it's going to include orthodontic surgery. And in fact, if you did nothing, the patient wouldn't have had the first 2 years of treatment. They would have just had the second part. So I would avoid those patients who have got class 3 skeletal problems. So in summary, let's pick the low-lying fruit. Now, the patient who may have a class 1, no skeletal issues, some minimal crowding, some mild overbite, they're the perfect cases to treat. You can treat that in 18 months or even less. That's a perfect type of patient to treat. But let's avoid those patients who are going to take longer than 18 months, those patients with high canines, those patients with open bites, those patients who have got a class 3 skeletal problem. So I ask you the question, do you have procedures in your practice to let you know what patients you should be referring out and what patients should you be treating? Are these standard protocols that everyone should be aware of?